So, you're staring at a patient chart, and the chief complaint is nausea and vomiting. It's incredibly common, right? But as we all know, finding the actual root cause can quickly turn into a massive clinical maze. Welcome to this explainer. Today, we're diving into the master blueprint for managing this exact presentation. We're going to break down the definitive algorithm step by step, giving you a crystal clear, structured pathway to diagnose and treat it effectively without getting lost in the weeds. Think of this algorithm as your medical detective map, where every single symptom is a vital clue. We're talking about a comprehensive workflow that takes us from pinning down the exact duration of symptoms all the way to managing those incredibly stubborn, refractory cases. Our goal today is to totally decode this map, so the next time a tricky case rolls in, you know exactly which path to take. Our dossier for this investigation breaks down into 6 key steps. We'll start by assessing duration and red flags, move on to ruling out offending drugs, check for mechanical obstructions, navigate gastroparesis, screen for metabolic causes, and wrap up with an escalation protocol for persistent cases.
Step 1 is all about setting the clock and hunting for any immediate, urgent threats.
Right out of the gate, the timeline splits our path. If a patient's symptoms are acute, meaning 7 days or less, we're usually dealing with things like gastroenteritis, a viral bug, or early pregnancy. In these scenarios, we typically just treat symptomatically with first-line antiemetics like metoclopramide or prochlorperazine. We don't need to launch a massive workup. But if those symptoms have been dragging on for 4 weeks or more, that's chronic. And that demands a full systematic evaluation covering everything from GI and metabolic to neurologic and psychiatric systems. But wait, before we go down either of those paths, we have to screen for alarm features. These are the flashing red lights of our investigation. If you're seeing bilious vomiting, severe abdominal pain, GI bleeding, or progressive distension, you stop everything. The same goes for neurologic deficits, significant weight loss, or new onset symptoms in a patient over 50. These are high-stakes emergencies. They require immediate urgent investigation, and they completely bypass that standard wait-and-see approach. Once we've cleared those immediate threats, we move to step 2, interrogating the usual suspects. It is absolutely crucial to check for offending drugs before you go hunting for complex zebras. Check the medication list first. Opioids are by far the most common culprits, but we also need to keep a close eye out for digoxin, phenytoin, carbamazepine, tricyclic antidepressants, and of course, chemotherapy agents. If any of these are in the mix, your immediate move is to discontinue the agent or rotate to a different med if they really need it. Honestly, this one simple step can solve the entire mystery. If medications aren't to blame, Step 3 has us looking for physical roadblocks in the GI tract. We have to map specific clinical features straight to our imaging toolkit. You're watching for clear physical clues: bilious vomiting, a visibly distended abdomen, intense cramping pain, or severe constipation. If the clinical picture suggests an obstruction, we do not guess. We get pictures. You start with plain radiography and quickly escalate to a CT of the abdomen if your suspicion is still high. And if you do confirm an obstruction, your tactics have to shift dramatically based on what kind it is. For a small bowel obstruction, it's mechanical approach. Make the patient NPO, start nasogastric decompression, correct their fluids, and get surgery on the phone. For a gastric outlet obstruction, you're looking at corticosteroids, PPIs, or endoscopic stenting. But please pay attention to this massive red flag for malignant bowel obstructions. Prokinetics are strictly contraindicated. Do not use them. You want to rely on octreotide and dexamethasone instead. Using a prokinetic on a malignant obstruction is literally like slamming on the gas pedal when the road is completely blocked by a concrete wall. Moving right along to step 4. If there's no physical blockage, we're likely facing a motility problem. Gastroparesis usually presents with nausea, vomiting, early satiety, and that uncomfortable postprandial fullness. But to actually diagnose it, you need hard proof. And here is a vital diagnostic trap. You absolutely must use a 4-hour gastric emptying scintigraphing study to prove delayed emptying. A 2-hour test is just inappropriate and won't give you the definitive answer you need. Once you've accurately diagnosed gastroparesis, the treatment plan is highly structured. First-line therapy is usually metoclopramide, which has the strongest evidence behind it, or erythromycin. And don't underestimate dietary tweaks here. Small, frequent meals while cutting out high-fat and high-fiber foods are paramount. If the patient is refractory, we escalate to 5-HT3 antagonists like ondansetron, NK1 antagonists, or phenothiazines. And for the absolute hardest cases where medical therapy totally fails, the algorithm points us to advanced interventions like gastric electrical stimulation or GPOM. If the mechanics and motility are fine, step 5 has us hunting for invisible chemical imbalances. Metabolic issues can perfectly mimic structural GI problems, so we run a comprehensive laboratory evaluation. We're checking electrolytes for hyponatremia or hypokalemia, checking calcium because hypercalcemia causes severe nausea, and looking at glucose to rule out DKA. We also evaluate renal function for uremia, along with liver and thyroid panels. And here is a massive one. A pregnancy test is absolutely mandatory for all women of childbearing age before you proceed. Missing a pregnancy or assuming a patient's nausea is just functional when they actually have uremia is a totally avoidable pitfall. You just fix the underlying metabolic abnormality before throwing symptomatic treatments at them. Finally, step 6. What happens when the symptoms just won't quit? We use the escalation protocol. This is exactly where the art of pharmacology meets the science of the algorithm. We combine agents in a very systematic step-by-step way. Step 1. Titrate your dopamine antagonist to the maximum tolerated dose. Still nauseous? Step 2. Add a 5-HT3 antagonist. Step 3. Bring in an anticholinergic like scopolamine and maybe an antihistamine. Step 4. Add a corticosteroid. If we're hitting step 5, we're talking continuous IV or subcutaneous infusions. Step 6 explores cannabinoids or alternative therapies like acupuncture and CBT. The absolute final resort is palliative sedation. The secret to this escalation protocol isn't just throwing meds at the wall to see what sticks. It's about combination therapy that targets entirely different neurotransmitter pathways. This arsenal works best when layered logically. When you combine a dopamine antagonist with a 5-HT3 antagonist and an anticholinergic, you get this massive synergistic effect because you're blocking different receptors in the brain's vomiting center all at once. Even corticosteroids enhance efficacy when combined with metoclopramide and ondansetron. It's a calculated, multi-front attack. Now, as medical detectives, avoiding traps is just as important as the treatments. We've talked about the 4-hour gastric emptying trap and the deadly mistake of using prokinetics in mechanical obstruction. But check this out. Do not administer IV metoclopramide rapidly. It must be pushed over at least 3 minutes. Pushing it too fast can cause terrifying extrapyramidal effects like severe involuntary muscle spasms. Also, don't assume ketonuria indicates the severity of dehydration. It's just not a reliable marker. And finally, never rush to surgical interventions for gastroparesis without totally exhausting your medical options first. If you take away just one pearl from today's explainer, let it be this golden rule. When you're faced with a perplexing case of nausea and vomiting, remember, drugs, obstruction, metabolic causes. Always check these 3 domains before assuming anything else, and especially before you just label a condition as functional. Ultimately, managing nausea and vomiting takes patience, a highly structured approach, and a bit of detective intuition. The next time you face this complex presentation, will you be the clinician who systematically rules out every single reversible cause? Because as this algorithm clearly proves, the answer is usually hiding right there in the pathway, just waiting to be found. Thanks for joining me on this explainer, and keep digging for those clues.